Thank you, Donald. And our next speaker is Dr. David Hart. Dr. Hart's a professor in the Department of Surgery and in the Faculty of Kinesiology at the University of Calgary. He's also a longstanding member of the McCaig Institute for Bone and Joint Health, and he's been interested in growth, response to injury, and degeneration of connective tissues of joints with a particular focus on sex-based differences. He's published over 500 articles in his career on some of these topics, so we're very happy to have him join us. Come on up.
This one, this is here. Middle is the pointer. This is advanced. Okay. Well, good morning. My name is Dave Hart. I'm a biologist. Been working with Renetta and Donald and the team for the past few years. I come from several decades, I hate to tell you how many, working on connective tissues, particularly of the knee, and particularly related to sex differences and how they're regulated. Oops. My slides are somewhere. Ah. Okay. So what we're going to talk about today is some of the biology related to joints and how joints are affected by hypermobility and what might actually be happening in the joints which lead to the hypermobility. Connective tissues, as Renetta mentioned in her introduction, are the focus of what's happening. These connective tissues of the musculoskeletal system are heterogeneous. They're designed to operate in unique environments. So in the knee, we have all kinds of different tissues. We'll talk about that. And they're different in the shoulder, the ankle, skin, lung, heart. They're not all the same. They're all very different. What they're made of and how it's organized are critical to how they work. And they're consisted of collagens, which we'll talk about. Those are the structural proteins. Proteoglycans, which are molecules that are mostly sugar. Proteoglycoproteins, which are proteins with a little bit of sugar. Other proteins and enzymes, molecules that help change the structure and function of the tissues. So each tissue also contains cells. A lot of times we forget about the cells, but they're important because they keep the tissue happy and functional. Now, the next thing to point out is that a tissue such as the knee, or a joint such as the knee, actually operates as an organ. It's an integrated organ system comprised of a whole bunch of different tissues, but they all have to work in concert. They have to function in a coordinated fashion. We don't think about it. We walk across the street, our knee works. All those bits are working. We don't even think about it. All of the coordination occurs in a dynamic fashion. From the time we're a fetus, we're born, we grow, we become skeletally mature, and we get old. This coordination of how these tissues work together is different in males and females. So puberty, pregnancy has been mentioned, menopause, and for males, we throw in andropause. Now, all this process of coordination, growth, etc., is influenced by our genetics and our experiences, such as injuries. Now, on the left, hopefully, this is a knee. Oops. I'll get used to this. This is what a knee looks like when you take an image of it. You see the bone where the pointer is, that's the femur. and over, oops. I'll get used to this. Anyway, there. The patella, your kneecap, and then below it is your tibia, and then there are all the other bits and pieces. They're all different. They're all made of the same things, but different proportions, different kinds. On the right, you see a schematic of how this works together. The key element is the muscles, the red bits. Those are the important thing that makes the knee work. Okay. Next one. So these tissues are dynamic. Hopefully you can see this, but on the left, on the top, you see the medial collateral ligament. This is the ligament on the inside of your knee that stabilizes it. This is from an animal, but as it grows, you see that it changes. When it starts on the left, at 3 weeks of age, the collagen is all very small. And as we grow, by the time you get to be a year old, the collagen is bigger diameters. On the right, you see the big diameters? So as we grow and there's more demand on the tissues, it gets bigger. But even when it gets bigger, there's always some small ones around. So it's not all big. On the bottom is the patellar tendon of the same animal. And you see that on the right, on the bottom, the collagen is actually bigger than in the medial collateral ligament. The ligament is just a stabilizer. The patellar tendon makes your knee work. And it's loaded differently. So every connective tissue in the knee is different. You can't generalize. Okay, so what happens when joint hypermobility arises? Well, you can have a number of genetic mutations. These are in EDS syndromes, Marfan's, other syndromes, but then there's always a percentage that are undefined genetically. But many of these mutations, as you'll probably hear later, are in collagens, some are in proteoglycans, some are enzymes. So what happens is there's altered organ function. The joints are looser. So they're not the same as they are in people without joint hypermobility. Oh, wow. Okay. But the point is, all these mutations are affecting the tissues. How they're affecting the tissues, we don't know. One possible answer is that these mutations and changes affect the tissues so they don't mature normally. They don't go through that process that we showed. No, okay. Now, is this really feasible? Well, if we look at other situations, if you injure a ligament or a tendon as an adult, what happens? It's different. It doesn't recapitulate. Next. Oops, back one. So on the top on the left, the top, you see the normal maturation of a ligament. On the bottom, you see that the collagen stays small. It'll stay small for years. And I'm going to get thrown off the stage. And it stays weak. So the idea is that in people with joint hypermobility, one grows and matures, but there's maybe an inability to mature normally. Next one. Okay. So what can we do about it? Well, some people said, well, maybe we'll try gene therapy. No, it won't work. Been there, done that. However, as was said earlier, perhaps exercise, might be important to implement, and it has been implemented for some people. Now, as Donald said, we might be able to assess whether there are changes in looseness of the joints across the menstrual cycle. So we may only want to exercise at certain times of the menstrual cycle, not all the time when there's increased risk for injury. One last one, I think. So what do we want to do locally? Well, for one thing, most of the collagen assessments have been done on skin from people with joint hypermobility. And as I've said, joint tissues are not skin. They work in different environments. So we really don't know which tissues are being affected in the knee. As people aren't lining up to give me tissues, we have to probably use models of hypermobility. And so that's one of the things we want to do. And I think the last point there, we may actually want to start looking at phenotypes of people with joint looseness at intersections. For one, the boundary condition at pre-puberty to puberty, and also at the menopause or premenopause, menopause transition, because many patients have said that, and there are some reports to support it, that the looseness of their joints changes after menopause. Well, it turns out that happens in people who don't have joint hypermobility as well. So that's an aging aspect independent of the hypermobility. But I think it's important to focus on some of those transition points that will give us some insights into where and how these tissues are being affected. So at that, I'll quit.
All right, so we'll take questions now. We have about 7 minutes for any questions from the audience for either Dr. Hart or for Donald.
I have a question for Dr. Hart. Thank you so much. It was very interesting. I'm wondering if there are any studies that show if loading those ligaments changes the outcome. So if there are any images of, like you showed the injured, I believe it was the tendon, and how it didn't proliferate quite the same as it did in the first few months of life. And I'm just wondering if under load that would change. You do.
The short answer is no. The long answer is it usually goes the other direction. It's been shown that if someone tears their anterior cruciate ligament in their knee, which is common in women, they'll sometimes reconstruct it with a piece of the patellar tendon, the central third. That piece of patellar tendon is actually stronger than the ACL. But over time, that patellar tendon turns into a scar-looking piece of tissue, and then it undergoes stretching because it's loose. So your joint actually becomes looser again. So it goes from being strong to weak, but you never really see things go from weak to strong. But if you immobilize the joint, say you break a leg and your leg is immobilized, you can sometimes see large fibrils decrease and become smaller. So it seems that the tissues will become weaker, but it's hard to load it and make it stronger. But if you immunize a very young animal that does not have joint hypermobility, it won't mature. So it does require some loading to make the process work.
Hi, this question's for Donald. I had two quick questions. First of all, what is your ideal number for statistical significance for number of recruits? And then secondly, did you consider leg dominance when looking between the laxity and the two knees?
Yes, very good questions. For the first question, we're looking for ideally 20 individuals to see significance. Most of the previous studies in non-hypermobile individuals had about 14 to 16. And our power calculations show about that number of 16 is usually should be pretty good. So we're aiming for that. The second part of the question, the leg dominance one, is interesting because we did for figuring out how we could do these measurements, we studied like about 20 some healthy individuals, and those who had dominant side on the right knee had stiffer right knees compared to the non-dominant side. And so that could be an information. I didn't report on like dominance of these participants. We do have that information though, so we can double check it. But we did often see in the non-hypermobile population that the non-dominant side was generally the more loose knee for sure.
Awesome. Maybe we'll take your question and then we'll just go to the online questions.
Okay.
Go ahead.
Mine's for Donald. Is there exclusion criteria for your study, like people with hormonal birth controls or knee surgery, stuff like that? And are you just looking through one cycle or multiple cycles and getting information from a few? Or...
Great questions. I'll answer that backwards and start with the last question. So we're looking at one cycle because that's just where we're limited to with our data collection. Ideally, you'd do more, but we're just limited to one. We do one cycle of tracking to see what an individual cycle looks like and where ovulation happens so we can be certain of where our testing sessions are. And then for the second part, so there's some exclusion criteria. So like we're limited, so we can't really look at people that have like a knee surgery or a previous knee injury because that's going to affect the laxity and the looseness, right? So that'll be something that'll affect the interpretation. But for the hormonal contraceptive piece, we are looking at individuals using different hormonal contraceptives. So we are including individuals using those different kinds of them and things like that, because that obviously would change how the hormonal fluctuations are happening. So that could also affect the response in the knee joint, right? So we're also including those individuals as well.
Okay, so online, there's 3 questions that are pretty related. So 2 people want to know if there's any planned research upcoming looking at perimenopause and effects on persons with EDS, HRT, HSD, and HEDS. That's the first question. And relatedly, they're wondering if there's any changes in hypermobility due to menopause. Wondering if you're aware of any of the changes in hypermobility due to menopause are considered when diagnosing.
Yes.
You guys come to
I could take a little bit to it. I know there's not a lot out there looking at like what's happening like at the joints and stuff for those 2 timeframes, whether it's the perimenopause or the menopause. I have seen some literature reporting that so like the one study I was kind of talking about where they reported like more frequent injuries and more like pain and fatigue at certain points in lifespans, like the puberty, the menstrual cycle, or pregnancy. Those reports were lower after menopause, and so they reported less frequent like subluxations events and things like that. But I'm not really well versed in the diagnosing side of it, so I couldn't answer that part of the question.
I think part of the problem is dissociating the aging part with the menopause part. I mean, it's interesting that many of our joints get stiffer when we hit 40 to 45. You see a lot more injuries from runners, weekend warriors, etc., because our joints seem to get stiffer at that time frame, which is perimenopausal for many people. So it's kind of hard to parse out those 2 things. To clearly associate them. Now, why that happens in the aging process, it's not clear. Some studies in preclinical models have shown that some molecules start to disappear from the tissues. And they're the molecules that make the collagen fibrils slide. So if you lose those lubricating molecules, the tissues get stiffer because it takes more work to make them move. So the aging process and the perimenopausal onset, which is variable between women, is really hard to separate.
Yes, and I'll just add that you might have heard the Faculty of Kinesiology has recently received a lot of money to look at menopause, so that's good feedback for us to investigate that and its association with hypermobility. And stay tuned, Dr. Tinkle's going to talk about hypermobility across the lifespan. In terms of diagnosis, These criteria, as many of you might know, keep changing over time. Even in my career in the last 10 years, things have changed a lot. There's new criteria for diagnosing hypermobility in children now as of last year. So I would say stay tuned. As of yet, there's no specific criteria for postmenopause or perimenopause. However, when we're looking at the criteria for hypermobile Ehlers-Danlos syndrome, we do use historical criteria based on whether someone's prepubertal or postmenopausal, because we know that, for example, as people get older, they might not be able to get their palms to floor, but if they could do it before, we would include that as, a positive diagnostic sign. So I think that as a research and clinical community, we are sort of aware of these things. It's how do we formally be consistent in how we talk about them. So with that, I think we'll have to close the questions. We'll have another bio break, wiggle break. So please continue to mingle. And in about 5 minutes, Sid's going to do some more wiggle exercises. Thanks, everyone.